A 60-year-old gentleman. 6 days ago, this patient was admitted into local hospital, presenting with sudden chest pain for 6 months. Emerging angiography at a local hospital found the distal left main total occlusion, but unfortunately, the walk wire could not cross the total occluded lesion. After intracoronary thrombolysis, fortunately, the blood flow recovered to TIMI-3. Then this patient referred to our hospital. His risk factors include essential hypertension and diabetes. Lab test at our hospital showed his eGFR was 45, and his BNP significantly elevated. ECG showed pathological Q waves in these V1 to V3. Echo found abnormal motion of anterior and posterior wall, and his left ventricular ejection fraction 48%. He was diagnosed as STEMI, cardiac shock, diabetes, and essential hypertension. Next. This is the ECG at our hospital, and the ECG showed pathological Q waves in V1 to V3, AVR segment significantly elevated. Then second day at our hospital, this patient underwent coronary angiography with IVP support. The baseline angio showed mild to moderate stenosis in middle to distal right coronary artery with severe vessel tortuosity. From apical view and spider view, we could find distal left main trifurcation, 90% stenosis in distal left main, and LAD ostium. The ostium or left circumflex and ramus were almost normal. From epicranial and iocranial, we also could find 90% stenosis in left in LAD ostium and moderate stenosis in middle LAD. We could find the vessel was very tortuous and with severe aggravation. The middle ramus, we could find a moderate stenosis. After discussion with cardiac surgeons, this patient and his family refused CABG. So today we plan to perform PCI for this patient. Considering the distal left main trifurcation and cardiac shock, so we plan to perform IVUS-Guided PCI with IVP support. For severe calcification in distal left main and LAD, we may use rotational isolectomy or intravascular lithotripsy standby if needed. That's all. Thank you.
Okay, thank you, Dr. Gao. Introduce this case. This is today's angiogram. We can see it's distal left main trifurcation because the case is a STEMI patient with the intracoronary thrombolysis and with the cardiogenic shock. So use the hemodynamic support is very important for this case. And we today's target is distal is trifurcation. So we can open the discussion for this case.
So we think before the procedure, which kind of left ventricular support devices we usually use for this case? Just because we can see after antithrombotic therapy in local hospital, we can see the antegrade flow of the LAD and the circumflex was very good, but still severe stenosis located at the distal left main and the proximal LAD. So this is a typical trifurcation lesion, very complex anatomy of the distal left main. So we think the procedure of the PCI was not very simple, just because of how to protect so many side branch during the procedure. This is the first issue. The second issue, how to use intravascular imaging guidance, OCT, IVUS, or just angio. The third is how to wire LAD. There's so many issues we should pay attention during the procedure, and before the procedure, we should make a lot of plans.
Because the patient's cardiogenic shock,
yeah.
So probably we need the IBP, at least the IBP to support this patient. Because the patient will use the IBP to stable the patient, and pressure blood is okay, and more than 100 over the 70. So I think maybe IVP is enough for this patient. I don't need to ECMO or another mechanical support.
Which kind of wire you will use for is your? I mean, so which kind of wire is your first choice?
Okay. So to shape the wire is important for to this patient. I want to use the run-through wire
Okay.
to shape the two curve for this wire.
Yes.
This LED is a big angle,
Yes.
so I think it may be difficult to wire this LED. Okay.
Okay.
It's 7 French from the radio access.
Yeah. So we can see severe stenosis at the distal part of the, yes.
Okay.
Okay, very,
Okay.
very easier
Yeah.
for you to
To
wire
fix it.
LED.
Yes.
Okay.
Okay, we can see this.
Severe angulation at the proximal LED.
Yeah.
Yes.
For this particular patients, for the distal nerve main, I want to use the IVUS,
Yes.
not to guide the PCI.
Yes, we think for the left main, bifurcation or trifurcation,
Okay.
especially
For the
for we
spider
want to detect the osteo left main, IVUS is better than the OCT. And another question is the patient left ventricular function is not very good, so we don't want to use contrast so much volume.
I want to advance another wire into the ramus and the circumflex
Yeah,
to
yeah,
protect,
yeah.
and then check IVUS.
Yes, very, very good. So we can see Dr. Ge use the 3 wire to go into the distal AD, distal circumflex, and the ramus. You don't want to pre-dilate first before I was checking.
Yeah.
Just because distal left main was a very severe stenosis. If we check the IVUS,
Yeah.
Yeah, the distal reference is 3.3.
this is distal AD.
Yeah,
Okay. How about the proximal AD?
this is the proximal LED.
Yes.
It's the ostium LED. The vessel diameter is about 4.5.
4.5. Okay.
Yeah.
Okay.
And the netness from the distal landing loop to ostium LED is about 34.
34.
Yeah.
That's very, very good. Very, very important data.
And the whole netness from the distal reference to proximal left main is about 70.
Okay. Okay. So, Dr. Ge, would you check another vessel's IVUS?
Yeah, I want to check the IVUS for the circumflex.
Distal circumflex vessel is normal, and the vessel diameter is about 3.5 millimeter.
3.5.
Yeah. And here we can see eccentric plaque.
This is a ramus.
This is yeah,
Mm.
ramus and LED join left main.
So this
This is
left
distal
main,
left
this is,
main.
yes.
Okay, stop.
Okay, I will stop. The area is about 89
Okay.
meters square, and the prolapse burden is about just 54%.
Yes. Yes. So, Dr. Ge, would you check the ramus IVUS?
Yes.
Ramus is normal.
Yeah.
It's normal, no plaque.
So because based on the IVUS results, is ostium the circumflex or ramus is normal.
Yeah.
So I just want to use the wire to protect these two side branches.
Yes. Yes.
So first of all, I want to use the non-compliant broom to dilate this LED and the distal left main.
Which size of the balloon?
This is 2.5.
2.5 NC balloon.
Yeah, and simple.
To predilate. So from the IVUS, we can see the plaque characteristics of the mammoth opposite the side branch was not calcified lesion. So that's why we cannot see the cranial shift. If we can see the plaque characteristics was calcification opposite the side branch. If we predilate or standing mammoth, we can see the cranial shift easily.
Okay.
For this case, we cannot see the so many severe calcification opposite the side branch. So after 2.5 balloon predilation, so next
yeah, based on the IVUS result, we can see some of the severe calcification located in the distal nerve main.
Yeah.
So I use the scoring balloon, 2.75 scoring balloon, to prepare this lesion, calcification lesion.
For the distal left main or
yeah,
LED?
For 30. 30. 30. 30.
30.
Yeah, 30. for the
3O.
distal nerve man.
This is
Can you-
3O.
Yeah, 3O
Okay.
is balloon expansion very well. Here, 6,
What's the pressure?
6.
6.
6.
Okay.
Here is okay.
Yeah.
Just because at the angulation side, yes, here.
Yeah, here.
No.
Oh, good.
Original
Yeah.
to compare
Yeah.
with final result. Original. So final result, we can see the flow is very, very good.
Yes.
And we cannot see any influence of the osteoramus and osteo circumflex. What's the size of this balloon?
It's a 3.5.
3.5.
Yeah. Okay.
How to precise located at the
6,
balloon side?
8,
8.
10,
It is
10.
3.5.
10, 12.
NC balloon.
NC, but yes.
10.
What's the pressure?
10.
10.
10.
So another question, do you want to standing now or want to check the IVUS?
Yeah, I want to check IVUS.
Yes, check the IVUS. Yes, we will see your preparations result.
Yeah.
After 2 NC balloon, 1 scoring balloon.
It's
Yes, we can see
the crack.
Yeah, the crack.
Yeah.
The crack of the calcification. So based on the IVUS detection, we select the landing zone, the middle ARD without any plaque burden over 50%, no soft plaque there.
Okay.
What's the size of the stand, Dr. Ke?
It's 3 and 33.
33.
33.
Yes.
What's the brand of the stand?
Firehawk.
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 Okay, this
Okay,
is
it's
a
easy.
domestic jugular stand. So this is a 3.0 stand.
8.
Yeah.
Yes.
9.
But
10.
the proximal reference diameter of the ARD was 3.54040. 40. So you will use a 4.0 stand to connect with the 3.0 stand.
Probably we use 3.5. It's enough for the
3.5 is better.
bet. Okay.
Reference diameter
Yeah.
4.0. Or from
Yeah.
media to media or
Media to media.
is 4.0.
Yeah.
Okay, 3.5 is okay.
Okay.
Just okay.
Yeah,
Okay.
I think
No
it's
Yes,
problem.
I think
This,
overlap.
That's good.
Yes,
Yeah,
change
yeah.
another view.
We move to the.
So how about the
but-
proximal landing zoom?
Yeah. Yeah, I think it's good. Pull back a little bit.
Yeah. I think so.
Up. Yes.
This is 3.5, 38.
38, yeah.
9. 8.
So for this case, because this distal nerve vein trifurcation, I want to first to use the 4.0 non-compliant balloon to port the distal nerve vein, and then to exchange the rewire into the rams and circumflex.
So this is the NC balloon for port.
Yeah.
NC.
Could you tell me is any difference of the port balloon compared with the NC balloon for port tactic?
Yeah. Actually, we have another port, port balloon.
Yes.
It's very short, very short. Next, I may want to change the sun branch wire.
Okay. So we still don't know for the one stand tactic, a crossover tactic from the LED to the left main for this left main bifurcation. And if there is no influence of the side branch of the circumflex and the ramus, do you perform the kissing or not routinely?
So probably I have to, based on the post-dilate the LD and the distal nerve main, and to check the ramus and the circumflex osteum, to make sure if the cranial or plaque to move into the osteum, sun branch osteum, to design to post kissing balloon information or not?
Yes, there is no consensus of final kissing with one-strand tactic post one-strand means crossover tactic. If there is low influence of the side branch, even with large side branch or small side branch,
it's
there is
not
no consensus of
happening.
the routinely final kissing. So that means we don't know kissing or not, which is better. For the clinical outcome, there is no difference. So what's the next step?
Yeah, to change the wire into the circumflex.
Yes. Which kind of the wire?
This is CM blue, new
Still
one.
CM blue. This is technical issue. Use a knuckle technique.
Yeah, I think it's
Sometimes we use double channel caster. Sometimes we use IVUS checking.
Oh, I think it's under the.
This is a CM blue wire.
Yes, CM blue. Okay.
Yes. Easier.
Easy.
Okay.
1.5
So
Another issue is how to pulling back the jet wire. We can use a small balloon assist, and we can use ankle technique with ankle balloon in the main vessel, and we also can use another wire put into the aorta.
3 non-compliant balloon to post dilate middle LG.
3O.
Yes,
3O balloon.
Yeah.
This is 3O balloon for post dilation in the 3O stand.
14,
16.
16.
Okay. No, clear.
16,
18.
18.
Okay. 我们365就好。
16,
18.
18.
Here. And go.
3.5 거야. 18,
16, 18.
16, 18.
So what's the reference diameter of the left main?
5.5.
5. Okay.
Yeah,
Five.
After that, we will check if there is manipulation of the stand structure. We will use a large balloon.
Large balloon, yes.
Prepare the 5 balloon.
12, 16, 14, 16.
Yeah. Okay.
After standing, we can see the angulation was changed. This is 5 balloon.
Yeah, this is 5 balloon.
Yes.
Okay. 10.
What's the pressure?
10.
10.
Yeah. 12. Okay. 12. 14.
14.
So we can see with the unprotected left main trifurcation lesion with IBP support for this case, the whole procedure was very, very stable. The key point of this procedure is to make sure the stand shoulder was in the stand. We cannot touch any area beyond the stand. Okay.
Okay. We
This
check
is 5.
IVUS.
Yes, we check the IVUS.
Yeah.
If there is still under expansion, okay, we can use.
This is a distal left main.
Yes.
Yes.
I will check the area.
Yeah. Oh.
No, sorry. Area not more than 10 millimeters.
So how about the
8.6 millimeters.
2.6. Prepare the 4.
Yeah.
How about the expansion rate?
14.
Yeah, 14. This
So expansion was about 60. I mean, this the left main.
So
no. This is the proximal left main.
Yes.
Yeah, I use the 4.
This is the proximal.
Thank you.